All right, in the second video on cardiovascular physiology, we're going to look at the whole, what's called the cardiac cycle, which is essentially one heartbeat and one cycle of systole and diastole. We'll look at the mechanical events. We'll tie in the electrical events that we went over in Cardiac Physiology 1 into this. And that all can be put together into what's called the Wiggers diagram. We'll look at the concept of cardiac output and stroke volume. Then we'll look at the regulation of blood pressure and a very important system called the renin-angiotensin-aldosterone system, and look at the concept of baroreceptors, which we just briefly talked about in the last video. Then I'll finally jump into cardiovascular phenomenology. So talk about the heart and the feeling life. Is the heart really a pump, or is it more complex than that? And how the cardiovascular system really is the prime regulator of your inner warmth and what we might refer to as our warmth body, our body of warmth, and how that correlates with Chinese medicine. So as I mentioned before, the heart is usually conceived of as a dual pump. We'll just start with that analogy first. Again, we'll go into this question later. Is the heart really a pump, or is it more complicated? But it's easier to think about the physiology from this way. And like with any pump, there's a contraction phase. Again, that's systole, and that's when the blood will be ejected from the heart. And this is really focusing on the events in the ventricles. So when we say systole, although our atria also undergo systole, we're really focused on the ventricles because that's where most of the muscle activity and the blood ejection is occurring from. And then diastole would be the relaxation phase, and that's when the blood will fill into the ventricles and refills and resets for the next cycle. So we're really focused more on the ventricles here. We can really think of the atria as more extensions of the venous system, the vena cava and the pulmonary veins, respectively. So they're kind of like enlargements of the veins. So again, they're very thin-walled muscularly, and so we don't really look at systole and diastole as much in the atria. One contraction relaxation cycle is known as the cardiac cycle. And at an average heart rate of 72 beats per minute, each cycle is about just under a second, 0.85 seconds long. We spend about 0.3 seconds in systole and a little bit longer, about a half a second in diastole. Now, there's different events in the cardiac cycle, 4 basic events, 2 of them occurring in systole, 2 occurring in diastole. So let's just go through these. And again, it's going to be important to kind of keep all these different things in mind. Let me just review here again quickly. If we look at the heart, we of course have 4 valves. We have our 2 atrioventricular valves, our tricuspid valve, and our mitral or bicuspid valve, separating the atria from the ventricles. And then we have the, not really shown well here, but we have the pulmonary valve and the aortic valve, which will be the separating where the blood will go from the ventricles out to either the lungs or the aorta. All right, so let's look at the cardiac cycle and how it correlates with the valves. And remember, just finally, that valves closing are what create the heart sounds. So when we hear the heart sounds lub-dub, lub is really the closing of the AV valves, the mitral and the tricuspid. And the dub is the closing of the pulmonic valves, and that would be the aortic and the pulmonic valve, the so-called semilunar valves. So the events in the cardiac cycle will be, number 1, we start at what's called isovolumic ventricular contraction. So this is essentially where we start with the ventricles filled, and we're just going to focus in this case on the left ventricle for clarity. So again, the events are happening in the right ventricle, but we'll start with the left. So imagine the left ventricle filled with blood. The mitral valve on the left side of the heart and the tricuspid on the right side of the heart are closed. And the semilunar valves are also closed, so no blood is being ejected from the heart. So the very first part of the cardiac cycle is when the ventricles start to contract, but the valves are all still closed, and that's going to build pressure in the ventricular chambers, and that's called isovolumic. In other words, the volume doesn't change, but we're starting to squeeze the ventricles, ventricular contraction. So the volume is constant, and we start developing tension across the cardiac muscle in the ventricles, and the pressure begins to rise in the ventricular chambers? Well, the pressure will eventually get to the point where the semilunar valves are going to open. Remember the AV valves, the mitral and the tricuspid, we talked about in the cardiac anatomy section, they are anchored by the chordae tendineae and the papillary muscles. So as the pressure builds in the ventricle, it will not backflow under normal circumstances into the atria. It should stay in the ventricles, and when the pressure builds enough, it's going to open instead the aortic and the pulmonary valve. And so blood will be ejected. And this is step 2 of systole, which is the actual ventricular ejection. So in this case, the AV valves are closed, the semilunar valves now open, and blood is ejected from the heart. The volume of blood ejected from each ventricle during systole is called the stroke volume. So that's how much blood actually leaves the heart with each heartbeat. Contrary to what you might think, the heart actually never fully ejects all the blood in the ventricles. It only ejects a portion. And we'll look at what a normal kind of stroke volume and output from the heart is here coming up. There's a small amount that remains in the ventricles at the end of systole, and that's actually called the end systolic volume. This is actually incorrect here. That should be end systolic volume, ESV, end systolic volume. And so a little bit remains there. Then, as the blood is driven out of the ventricles and the pressure in the ventricles drops, the pressure both in the arterial tree and the pulmonary tree is greater than the ventricular pressure, and that closes the semilunar valves. So the aortic and the pulmonary valves close. The ventricles then actually relax, and there is just the end systolic volume that remains in the ventricles at that point. Then, as the pressure continues, as the ventricular wall continues to relax, and the pressure drops in the ventricles, the AV valves now open, and blood is going to rush from the atria into the ventricles. And so that's going to cause ventricular filling. So that's the final phase there. Now, right before this ventricular filling is over, right before we go back to the isovolumic ventricular contraction phase, the atria are going to contract. So atrial contraction happens here in step 4. And that's going to provide a final little kick of pushing the blood from the atria into the ventricles. And then we go back, the AV valves will close as the ventricles are filled now with blood, and then we go back to cycle number 1 and we repeat the whole loop. And so that is a complete cardiac cycle. Again, 2 of these events are in systole, 2 are in diastole. Now coming up here, we're going to integrate this entire cycle with the electrical activity in the heart. Remember, it's the depolarization of the atria, which is going to start at the end of step 4 here. That's going to cause the atria to contract. And then that signal is going to pass down into the ventricles, and that's going to start step 1 with the isovolumic ventricular contraction. The ventricles will continue to contract into step 2, and then by step 3, the ventricles, the signal has passed through the heart, and at this point the ventricles are relaxing, and we go into step 3. So it's important to kind of keep these mechanical events that are occurring in the heart, how the blood is also flowing in the heart. You put that in context with the electrical activity in the heart as well. So that's one complete cardiac cycle. So again, putting this together from a different context with the cardiac cycle, we can look at the ECG and the different events there. So remember, the P wave is the depolarization and then contraction of the atria. And that's going to mark the beginning of atrial systole. So this is going to be right at the end of the phase 4 of the cardiac cycle that we talked about in the last slide. And that's going to be at the end of ventricular diastole. Then the QRS complex marks the beginning of the contraction of the ventricles, and that'll mark the beginning of ventricular systole. And that is going to be going into step 1. That would be the isovolumic contraction. Then when the semilunar valves open, blood is ejected from the heart, and that's step 2. Shortly after that, the T wave represents the repolarization of the ventricles. And that's going to that's going to occur right at the beginning of ventricular diastole, the relaxation. And that will go into stage 3, and then stage 4 again, and so forth. So basically, we can correlate all those mechanical events with the electrical activity here in the heart. And here's yet another picture showing that going through systole and diastole. So you can read through that. I won't go through all that again. But it's important to try to correlate the electrical events, the events occurring in the valves, which we can listen to with the stethoscope, and the actual blood flow through the heart itself. It can seem very confusing at first, but once you kind of get the hang of it, it all begins to make sense. One final point I'll make here is, again, if we look at the systole and diastole, we spend less time in systole, and that's marked in the darker green here, than diastole, which is marked in the lighter green. Now, again, the closing of the valves will essentially give us our heart sounds, and those can be heard with a stethoscope placed against the chest wall. And we do this process. This is known as cardiac auscultation. Auscultation is listening to the heart with the stethoscope. We put the stethoscope, usually both the diaphragm, we do it first with the flat part of the stethoscope, and then we do it again with the bell, the other side of the stethoscope. That'll pick up more low frequency noises versus the diaphragm will pick up more high frequency sounds. Increasingly, people are now using electronic stethoscopes, which can record all that, and then we can analyze the heart sounds more accurately. But basically, we place the either the bell or the diaphragm of the stethoscope on different portions. First one would be to listen for the aortic valve. We put it at the second to third right rib interspace to the right of the sternum. To listen to the pulmonic valve, we put it in the second to third left interspace. To listen to the tricuspid valve, we put it along the fifth interspace at the left sternal border. And then for the mitral valve, we put that at the apex of the heart. Again, that will be roughly in the mid-clavicular line at the fifth interspace. And this is really following the outlines of the heart. So again, the heart is kind of oriented this way. Remember, the aorta is kind of weird where it wraps around this way, and then the pulmonary artery actually comes off this way, and the aorta loops around. So that's why we listen at these different spaces for the different sounds. So that will tell us, by listening those different places, we can actually listen to the sound of the different valves and see if there's any abnormalities. A murmur is a heart sound in addition to the normal lub-dub. So this could indicate a lot of different underlying heart defects, such as a narrowing of the valve or a leaky valve. And so a narrowing is called stenosis, a leaky valve is called valve insufficiency. Occasionally, remember we talked about the foramen ovale, which was the normal in the fetus. It's a hole in the septum that separates the right from the left atrium. And the opening there allows blood to pass from the right to the left atrium, thereby bypassing the lungs in the fetus. So the blood flow doesn't go to the lungs. And that in some people can remain open, causing a patent foramen ovale. And that also can be heard as a heart sound, as a murmur with the stethoscope. And this would be an example of a septal defect. The timing in the cardiac cycle, whether or not it's in systole or diastole, and the murmur is going to be crucial for the diagnosis of the underlying defect. So again, just to review the heart sounds, which we discussed a little bit previously, the lub is the S1, and that's going to result from the closure of the AV valves, the mitral and the tricuspid, and that marks the beginning of systole. So in the cardiac cycle, if we listen to lub and then dub, lub marks the beginning of systole, and dub is actually going to be marking the beginning of diastole. And then the next lub would be systole and so forth. And it results from the kind of valve snapping back and vibrating a little bit. That's what causes the sound. We have two components to S1. That's M1, which is the mitral valve closure. T1 is the tricuspid valve closure. And normally the M1 precedes just slightly T1. We can have a split S1 when T1 is a little bit delayed, and that can be a sign of a right bundle branch block. In other words, a conduction problem through the right bundle branch. So just listening with your stethoscope might give you an indication of that. Again, we'd use an EKG or an ECG to further diagnose that. So that's the first heart sound. The second heart sound, a lub, would mark the beginning of diastole. This is the closure of the semilunar valves. It's a little bit, sounds a little lighter than the lub, and that's because the semilunar valves are a little smaller than the AV valves. We have two components here. We have the aortic component, A2, and the pulmonary valve component, P2. And normally A2 precedes P2 just a little bit. That's because the pressure in the arterial system is a little higher than the pulmonary system, and so it should close the aortic valve sooner. A split S2 can either be physiologic, meaning it's benign and normal, and that can occur during inhalation, or you can have a pathologically widened or split S2, and that could again be a sign of a bundle branch block, stenosis of the pulmonary valve, or an atrial septal defect. And so then we do further testing to investigate that. A very loud P2 could indicate pulmonary hypertension, so increased blood pressure in the pulmonary tree, or even a pulmonary embolism. And a soft S2 could indicate aortic stenosis. So those are all different things we can listen to with the heart sounds. There can be extra sounds. So we normally talk about S1, S2, lub dub, but we can have two extra sounds on top of that. And that could be, these are called gallop rhythms. So there's a third heart sound, and this is actually heard just after dub. So basically you'd hear lub dub dub, lub dub dub, lub dub dub. Again, we'd have to be clear to differentiate that from splitting. So lub dub dub would be more of a splitting, but lub dub dub, or Kentucky, or sloshing in, all of these would be a third heart sound, S3, and that occurs at the beginning of diastole. Again, that happens right after the dub diastole. Best heard is a low-pitched sound with the bell of the stethoscope, not the flat part, the diaphragm, and it can be on either on the right side or the left side. And generally, when it's on the right side, it's going to increase with any inspiration by breathing in. The significance here is that in S3, the blood is oscillating back and forth between the walls of the ventricles as the ventricles are filling during diastole. And the chordae tendineae are tensing, they're kind of snapping too. And it's typically normal in people under 40 and in some trained athletes, so it can be benign. Typically, it should disappear by middle age in most people, but if it comes back now, if you hear it again in an older person, that could indicate heart failure. So there's a overload of blood occurring in the ventricles. So that's an S3. And S4 is happening right before systole. So it's still in diastole, but right before systole. So this is, we use the kind of, it sounds like Tennessee, so, or a stiff wall. So instead of lub dub, it's lub lub dub, lub lub dub. So right before the first heart sound, we hear S4. This is best heard at the cardiac apex with the person in what's called the left lateral decubitus position. LLDP, they're lying on their left side, their knees are up, and they're holding their breath, and that's when S4 is best heard. The significance here is it's caused by the atria contracting forcefully because the ventricles are really stiff. So remember, right before systole is when the atria contract. So that's occurring during the diastole, the ventricular diastole. And if the ventricles are very stiff and it's hard to fill the blood in there, the atria have to squeeze a little harder, and that's going to create this extra heart sound. This is always pathological. It could indicate any sort of left ventricular hypertrophy, like in hypertrophic cardiomyopathy, hypertension. It could be a result of aortic stenosis. So we'd go further, and I'll talk about different tools as we go into all those that we'd use to investigate. All right, so that's the third and the fourth heart sounds. These are known as gallop rhythms that may be heard in addition. Again, there's different murmurs. So for example, we might hear in the heart, a lub dub, lub dub. You might hear lub slosh dub, like lub dub, lub dub. And that would be a systolic murmur versus lub dub would be a diastolic murmur. And so we would hear different sounds at different places and different parts of the cardiac cycle depending on the underlying pathology. I'll have a whole little section on valve disorders that will just briefly talk about some of the more common ones that we need to be familiar with. So now that we know about the electrical activity in the heart, the mechanical events, the valves and how they relate to the different parts of the cardiac cycle, we can put all this together into what's called the Wiggers diagram. So this is a summary of the electrical and the mechanical events during a single cardiac cycle. So let's look at what's going on here. So first of all, we could start with the ventricular pressure line. That's this blue one here. So we start at the beginning of, here's isovolumic contraction. So this line here is the beginning of systole, right here. So the beginning of systole, remember the first phase is isovolumic contraction. So all the valves are closed, the ventricles are filled with blood, and the ventricles are starting to contract. And so the ventricles contract because the electrical activity, we're at the QRS complex, the electrical activity is spreading through the ventricles, causing the ventricles to contract. So at the very first phase, the pressure, which is this reading here, is increasing in the ventricles. Now, we eventually get to the pressure where the aortic, so we're just going to focus on the left ventricle again for clarity here. The aortic valve will open, and then blood is ejected from the heart, and now the pressure begins to drop again and goes all the way down. Here in the right is the ventricular volume. So notice that we start systole with the ventricles filled, and then the first part of systole, the isovolumic contraction, again, the volume doesn't change, but then the ventricles, the blood goes out. And so by the end of systole here, we have a little bit of blood remaining. That's the end systolic volume still in the ventricle, but it gets to the lowest level. In terms of the EKG or the ECG, we are after the QRS complex here, and the T wave occurs here, the repolarization of the ventricles. So that's systole. Notice that as we hit diastole, so this is the beginning of diastole right here, we go through isovolumic relaxation, and then we're going to get the filling. So the aortic valve is going to close at this point, because the pressure is dropping in the left ventricle. And then we get to a very low pressure in the left ventricle as the ventricular wall continues to relax, and the mitral valve will open. And now notice the blood is filling back into the heart. And so this is, again, the filling of the ventricles in diastole. And the pressure remains pretty constant, it's low pressure. This little spike A is actually the atrial systole. So the atria will contract at the end of diastole, right here. And this causes blood to be forced into the ventricles, and that gives a little spike in pressure and a little spike in volume as well. Remember the signal for atrial contraction, we see that on the P wave. So the P wave is here. And as the P wave occurs, that's indicating the electrical signal spreading through the atria. So that's atrial contraction. Then we get another QRS complex, and we get another systole, and we go through the process again. So that's the integration of the electrical and the mechanical and the valve events. Finally, we can listen to the heart sounds. Again, systole, S1 is the first heart sound. That's the lub, and that's going to indicate essentially the closing of the mitral valve here. So remember, heart sounds typically are indicating the closing of the valves. The normal heart sounds at least. And then S2, this is going to be the dub. That's the beginning of diastole, and that indicates the closure of the aortic valve. Again, looking at the left ventricle. And we can go through the same events on the right ventricle to describe it as well. So that integrates the sounds, the electrocardiogram, the ventricular volumes, the ventricular pressure, as well as the atrial pressure curves. The only other curve I didn't talk about was the aortic pressure. Notice the aortic pressure, of course, is going to increase as the blood is ejected. So the lowest pressure here is going to be around 80 millimeters of mercury. That's normal diastolic pressure. And then we get ejection above that, and that's going to peak out at your systolic pressure, in this case 120. So that would be a normal kind of pressure curve. If your systolic was 180, that means we're peaking all the way up here and getting a much bigger pressure wave. If your diastolic is at 100, again, we're just going to shift that curve upward. So that correlates it with the atrial pressure loop. So understand the Wiggers diagram. Try to go through in your mind and integrate all the different events of the cardiac cycle with these different events. And then you'll understand very clearly how we can, when we start talking about different cardiac pathologies, different events that might impede the different parts of the cardiac cycle will be more explainable. Now, a very important measure of output from the heart, would be cardiac output. And that's defined as the volume of blood ejected from each ventricle per unit of time, usually liters per minute. So how many liters per minute are ejected from the heart? That's cardiac output. And that the equation for cardiac output essentially is cardiac output equals your heart rate times the stroke volume. Remember, stroke volume was the amount of blood ejected with each ventricular systole. So with each contraction of the ventricles, that's the stroke volume. In the average adult, the cardiac output is about 5 liters per minute. That's all the volume of the blood, about 5.5 liters is a total average blood volume in the average person. Again, that's about 2.5 gallons or so, is pumped around the body in just over a minute. So tremendous volume of blood actually moves through the heart. The cardiac output can actually increase to 35 liters per minute in a well-trained athlete. So going from 5 to 35 liters per minute. And we can actually measure the cardiac output with ultrasound in a procedure known as echocardiography. I talked about that, or I will talk about that in the cardiac assessment video. But basically, electrocardiography, non-invasive using sound waves. We actually have different techniques. We can actually measure the flow of blood through the heart and the output through the aortic valve into the aorta. We can see how much blood is being ejected from the left ventricle. And normal left ventricular ejection fraction is between 55 to 70%. So that would be a typical normal ejection fraction. And that's a very important number to know for people with heart failure and so forth. When we start getting below 55, definitely below 50%, we start to see a lot of symptoms basically we see the signs and symptoms of heart failure. So again, we can measure cardiac output indirectly with the echocardiography. Can also do that with CT scans now and with different radionuclide tracers, but typically the echocardiography is the procedure that's preferred. And that can be done through the chest wall. For more accurate measurements, you can actually do it through the esophagus. Put an ultrasound transducer down there. There are very direct but more invasive methods called the Fick method or the indicator dilution method. I'm not going to talk about those. Those are used more in research settings, not so much in clinical practice. Now, very importantly, we need to know what are the factors that influence cardiac output. So changing either the heart rate or the stroke volume are going to change cardiac output. So what factors affect heart rate? Well, we've already talked about that. So autonomic intervention, sympathetic, parasympathetic tone. Increased sympathetics would increase your heart rate. Hormones, we talked about some of those. Thyroid hormones, for example, but also different drugs and whatnot like caffeine would increase your heart rate. Your fitness level and your age, all these would affect heart rate. Factors that affect the stroke volume would be the size of your heart, your fitness level, your gender, the contractility. How easy is it for the heart to contract? What's the duration of the contraction? How much blood is actually coming back to the heart in diastole? How filled are the ventricles? And that's called the preload or end diastolic volume. So at the end of diastole, the relaxation, how much blood actually is in the ventricles? And then how much does the heart have to pump against? So if there's a lot of pressure from like hypertension in the arterial system, the left ventricle has to constantly pump against that, and that is known as afterload. So both preload and afterload are important factors together with contractility that determine stroke volume. And so we can calculate stroke volume is really our end diastolic volume, so the volume of blood after the height of diastole, so the When the ventricles are fully relaxed and filled with blood, that's the end diastolic volume, versus the amount of blood that remains in the ventricles after systole, that's the end systolic volume, remember. Stroke volume is just the difference between those two. So any of these factors are going to affect the cardiac output. So since we talked about heart rate already, I'm not going to go into those factors here, but I do want to focus a little bit more on stroke volume. So again, cardiac output is heart rate times stroke volume, and the stroke volume is your end diastolic volume minus your end systolic volume. And there's three primary factors that are going to affect it. One is the preload, and that's again the same as your end diastolic volume. And the main determinants there are how much blood actually comes back to the heart. That's known as the venous return. It's also going to be dependent on the ventricular filling time, how long it takes the ventricles. So basically, if there's faster contractions, like with a faster heart rate, there's going to be a decreased filling time, and that's going to end up letting less blood come back to the heart, and so forth. But the main factor determining end diastolic volume is going to be venous return. How much blood comes back to the heart during each cardiac cycle. And that's dependent on something called the Frank-Starling mechanism. So Frank-Starling is interesting because of all the elastin and the way the cardiac muscles work. The more you stretch the heart, the stronger it actually contracts up to a point. So if you have an empty heart, it can contract with a certain rate. But if you stretch it, if you fill it with blood, it actually ends up contracting even stronger. So it's kind of like a balloon. The more you stretch it, and then if you let the air out, the stronger the force of pushing the air out will be, the more filled the balloon is. So that's Frank-Starling mechanism. So there's a relationship between ventricular stretch, essentially, and the force of contraction. So the contraction is directly proportional to the length of the muscle fiber. So increased ventricular stretching, you're going to increase force of contraction. Up to a point, and this is the problem with heart failure, and when the left ventricle becomes too large, it can become overstretched, essentially. It can also start to hypertrophy. You get too many cells, and Frank-Starling breaks down. So as the heart fills with more blood, the contraction actually goes down. And so that's kind of going too far, and that happens in cardiac pathology. But under normal physiologic conditions, Frank-Starling sort of predominates. The other factor affecting stroke volume would be contractility, and the main determinants are your autonomic system, hormones, and electrolyte levels. So positive inotropes, remember, increase the strength of contractions, and that would be your sympathetic, your catecholamines, norepi, and epi. Digoxin, which actually comes from Digitalis purpurea, medicinal herb. Digoxin is made into a medicine. Kind of use it less and less here in the United States, but it still has a role in some heart failure patients. But digoxin can basically increase the contraction of the heart muscle. And then hypercalcemia can also increase contractility of the heart muscle. Negative inotropes would decrease the strength of contractions, and that would be your parasympathetics. Beta blockers are the medications that block the beta receptors that the catecholamines, the beta 1 receptors that they bind to. Calcium channel blockers, we talked about those in the last video. They block the ability of calcium to get into the cell, and thereby it will decrease the contraction of the cardiac myocyte. Any sort of hypoxia, low oxygen, and low potassium, or I'm sorry, high potassium. High potassium will basically weaken the strength of contraction of the heart. That's called hyperkalemia. So that's contractility. The last factor that affects stroke volume is afterload, and the main determinant there is vascular resistance. So that would be your blood pressure in your arterial system in particular. So the ventricles essentially have to pump against that pressure. So we see increased afterload and hypertension. We also see it if the aortic valve becomes scarred and fibrosed over. That's called aortic stenosis. It becomes narrowed. And that can lead to a backflow of blood into the left ventricle. And so the left ventricle has to push harder. So the afterload would be increased. So preload, contractility, afterload are the three factors that determine stroke volume. And I put all that, and this is all summarized in this table here, and you can kind of read through that. But basically, this will help us understand heart failure. For example, we can have decreased contractility, and that will be what we call systolic dysfunction in left heart failure. We can also have a fact where the ventricles are not compliant, they get too stiff, and they don't fill adequately. And that would result in what's called diastolic dysfunction heart failure. So you can read through all the different factors there. But basically understand, first of all, what cardiac output is, and then what are the factors that affect heart rate as well as stroke volume. Finally, this graph puts it all together in terms of the heart rate for cardiac output, heart rate, and then stroke volume. So the autonomic intervention plays a big role in heart rate, hormones as well, and then this is actually indicating your stretch reflexes. That also affects the autonomics. But then factors affecting stroke volume would be your venous return, the filling time, the autonomic intervention hormones, and then your afterload, and that would be either vasodilation or vasoconstriction in the arterial system. And they all go into affecting preload, contractility, afterload, and that will affect the end diastolic volume and the end systolic volume. And that eventually affects stroke volume. So this is how we can integrate all these different factors together to understand how they can affect the heart muscle. So one final aspect, this is going to affect more afterload, but one final aspect of cardiac physiology we need to understand is the regulation of systemic arterial pressure. So remember, the mean arterial pressure is a difference between the systolic and diastolic pressures. And that is going to be the pressure in the arteries that will allow for perfusion into the tissue. So we have to have adequate pressure to maintain adequate perfusion. And there are four major factors that affect that blood pressure and that mean arterial pressure. And any of the changes in these will affect the overall pressures. So one would be cardiac output. So that's how much blood is actually pumped through the heart in 1 minute. So that's basically your stroke volume times your heart rate. And so that's going to be how much blood we have entering the arterial system. So that's one factor that maintains pressure. The other is the volume of blood. Now, again, the average volume of blood is 5 to 5.5 liters in adults. That can be reduced by things like severe hemorrhage or dehydration, reduced fluid intake, etc. There are several different hormones that maintain blood volume. One comes from your pituitary gland, and that's antidiuretic hormone, also known as vasopressin. What that does is it prevents, it's antidiuresis. It prevents the water from being lost in the kidneys, and that's going to increase blood volume. The other system, which will be very important for us to know about for blood pressure regulation, will be what's called the renin-angiotensin-aldosterone system, RAAS. And I'll just summarize it here quickly, but we're going to see it again when we talk about different medications. This is the target of many medications for blood pressure and so forth, and many of these are used in heart failure and other different cardiac conditions. But basically what happens is that the liver normally secretes this peptide called angiotensinogen. And so the liver makes angiotensinogen. It floats around in your blood. It's inactive. But if there is a change in the blood volume, so for example, if you, let's say, lose blood and there's decreased volume, or there's decreased perfusion for any reason through the kidneys, and there's many reasons for that. One is not common. You can actually have atherosclerosis in the renal artery, and so there's a plaque here, and that's called renal artery stenosis, and less blood flow will get into the kidney. Also inside the kidneys, not shown in this picture, there's little arterioles, and if your sympathetic nervous system is constantly elevated, if you're in that fight or flight state, the little arterioles get constricted in the kidneys, and that decreases blood flow into the nephron, which is the functional unit of the kidneys. So decreased blood volume, increased vasoconstriction of the arterioles, basically tells the kidney, hey, you're probably losing fluid somewhere, or we got a problem with lower blood volume possibly. Although again, it could be tricked, if there's a plaque here, or if you have that increased sympathetic tone, that's not truly a loss of blood volume. But the kidney doesn't know that, so it puts out its own hormone called renin. So renin secreted in those cases, and renin is going to convert angiotensinogen in the blood to another peptide called angiotensin 1. And that's going to circulate around the body. It's going to go through the lungs. And in the capillary beds in the lungs, there's an enzyme called angiotensin converting enzyme, or ACE. And ACE converts angiotensin 1 to angiotensin 2. And angiotensin 2 has a whole range of activities. Basically, what it's going to do, number one, it's going to act on your adrenal glands to cause the release of an adrenal hormone called aldosterone. I know this is a lot of steps, so we're almost done. So we get aldosterone secreted, and aldosterone has several effects. Number one, it tells the kidneys to hold on to more sodium. And when it does that, it actually holds on to more water as well. So that's going to increase blood volume. Remember the original signal, the kidney thought you were maybe losing water or you had a decreased fluid volume. So aldosterone is going to tell the kidneys, hold on to more water, hold on to more sodium. That will increase your blood pressure. And if it's from like a hemorrhage, that'll actually help stabilize you. If it's not from the hemorrhage, if it's for one of these other reasons, that's going to maybe give you artificially increased blood pressure. Another action of aldosterone is on arteries and arterioles. It causes the smooth muscle to vasoconstrict. That will also increase blood pressure. And the third action of the angiotensin 2 as well as aldosterone will be to increase your sympathetic nervous system activity. And that will increase your heart rate. And eventually that's going to increase your cardiac output. And that will increase your blood pressure as well. So basically, all these mechanisms come together to raise your blood pressure. So it's aldosterone, but also the angiotensin 2 that has all these different effects. There are angiotensin receptors on vascular endothelium, on the heart, and so forth, which help regulate all this. Jumping ahead, we'll see there's several major medications that are used for blood pressure. One of them is what's called an ACE inhibitor. It inhibits this enzyme in the lungs, angiotensin converting enzyme, ACE. And there's another group of medications now that are called angiotensin receptor blockers. So they actually block the receptor for angiotensin 2. And then there's a third set of medications which tell the kidneys directly, they're called diuretics, to increase excretion of sodium and water. Finally, there's a fourth set of cardiovascular medications that blocks the calcium channels in arterioles and arteries to cause them to vasodilate. The calcium channel blockers also cause the heart rate to slow down and the heart to contract less strongly, so that decreases cardiac output. So we'll talk about all these medications as strategies for the treatment of hypertension. But be sure you're able to understand this renin, angiotensin, aldosterone, or RAAS system. Very important for our future discussions here. Okay, so that's the second feature that maintains blood pressure. A third feature would be peripheral vascular resistance, and that's caused by usually vasoconstriction, vasodilation, and that's regulated by the RAAS, as we just said, as well as your sympathetics. Those are the two main vasoconstrictors. And then vasodilators would be things like nitric oxide and those other compounds we talked about a couple of videos back. And then a fourth property, which we usually don't consider for blood pressure, would be the viscosity of the blood. And that's typically not going to change very much unless you have a condition where, for example, you have a lot of cholesterol in the blood or a lot of triglycerides, very, very high levels. The blood becomes more viscous, and that's going to increase the blood pressure. You can also have an increase of red cells. That's the opposite of anemia. That's called polycythemia, where you get too many red blood cells. And that's often due to a bone marrow problem where you're making too many red cells. So all of that will cause the blood to become more viscous. So those are the four factors that work together to maintain blood pressure. Here I've just summarized once again the RAAS system, just kind of for your own reference there. But again, the basic process is liver secretes angiotensinogen at a constant rate. It's inactive in the blood, but then anytime the kidney perceives a decrease in renal perfusion, it's going to basically secrete renin, another protein, which works as an enzyme to catalyze the reaction between angiotensinogen to angiotensin 1, or AT1. And then in the lungs, ACE, angiotensin converting enzyme, in the capillary beds in your lungs will convert angiotensin 1 to angiotensin 2, and that's going to bind to angiotensin receptors. Actually, an ARB, so it's AR. An ARB would be an angiotensin receptor blocker. So the action of angiotensin 2 would be to increase sympathetic activity, increase the aldosterone from your adrenal cortex, as I talked about in the last video, increases vasoconstriction, increases through aldosterone sodium and water retention, will increase blood pressure. It has other effects. It unfortunately causes remodeling of your vasculature, so it can cause more fibrosis and constriction on your vasculature. And it also causes the left ventricle of the heart to enlarge, and that can cause left ventricular hypertrophy. And over time, that can cause a breakdown of the Frank-Starling mechanism, so the ventricle functions less efficiently, and we can start going into heart failure. So that's the summary again of the renin angiotensin aldosterone system. Finally, I want to talk about how the brain integrates blood pressure. Part of that has to do with the baroreceptor reflexes that we spoke about earlier. So these are pressure receptors, and there's two main pressure receptors in the body for the arterial system. One is found in the carotid artery. It's actually the bifurcation in the neck of the external and internal carotid artery. So that's the carotid sinus. And then there's a baroreceptor in the arch of the aorta as it comes out of the heart. So basically, as the blood pressure increases, pressure inside the arterial system increases, that increases the stretch across those receptors, and the receptors will fire more quickly. And those nerves then, those sensory nerves will go back to the brainstem, and then there's an integrating center in the brainstem, which will take that information and integrate it with the autonomic information. So again, the carotid sinus is located at the bifurcation of the carotid artery, this is very highly innervated with different nerves, and again, they're very highly sensitive to stretch. This is why massaging that area in the neck, as we'll see, will actually artificially trigger stretch. And as a result of that, what that's going to do is send the impulses back to the brain, basically telling the brain, hey, there's too much pressure in your system, and they're going to increase your parasympathetic output. And that's why we can actually get an increased vagal response by massaging the carotid sinus. And if a person is in a tachyarrhythmia, has an abnormally fast heart rate with too much sympathetic tone, that can actually bring them out of the arrhythmia. So some of those supraventricular tachycardias I talked about can be aborted by massaging the carotid sinus. And some people, though, too much massage there, they pass out. Their sympathetic tone drops and their parasympathetic tone is excessive. The aortic arch baroreceptor is in the arch of the aorta. All the afferent information then is going to travel via neurons to the brainstem into what is called the medullary cardiovascular center. So by the very name, this is found in the medulla, the very lowest part of the brainstem. And this is going to integrate all the information from your baroreceptor reflexes, and it's going to adjust the blood pressure via your parasympathetics and sympathetics. So an increased firing of the baroreceptors indicating stretch, or if you massaged it, would basically cause a decrease in sympathetic outflow to the heart, to the arterioles and veins, will cause an increased parasympathetic output to the heart, and that will result in decreased heart rate, decreased cardiac output, and decreased blood pressure. And again, if you're in a situation where you have a supraventricular tachycardia, that would be a good thing. It'll slow the heart rhythm down, and that might abort that arrhythmia, but it can also cause you to pass out if there isn't such a thing going on. A decrease of the baroreceptor signals will cause the sympathetics to increase, parasympathetics to decrease, and that will increase the heart rate, cardiac output, and increase blood pressure. The decreased arterial pressure also will trigger the release of angiotensin 2 and vasopressin. So as we talked about in the previous slides, 2 slides ago, that also will help regulate and increase blood pressure. There are other signals such as decreased arterial oxygen concentration that also influence the rate of firing of the neurons in the medullary cardiovascular center. So this center is also sensing oxygen levels. And all of these are integrated together, and they're going to basically help to maintain normal blood pressure, despite things like if you're exercising or if you have a fever or a hemorrhage, etc. So there's a constant integration of all this information to maintain a normal blood pressure under all those different changeable conditions. Now, these are minute to minute, second to second changes. So the nervous system and the reflexes really help to integrate in very short time periods your blood pressure. Longer term changes really have to do more with all your hormones and how they're functioning. Unfortunately, the baroreceptors, if you have high blood pressure over a long period of time, they can become reset to the higher blood pressure level. And so unfortunately, they will actually help promote your higher pressures after time. So that's one of the challenges we have getting blood pressure lowered after it's been elevated for a long period of time, is because the baroreceptor reflexes have essentially reset. So that's the medullary cardiovascular center and how it integrates all the baroreceptor information and then regulates autonomic output to the heart and the vasculature. Okay, so that wraps it up for all the basic information you need to know about cardiovascular physiology, regulation of blood pressure, regulation of cardiac output, the stroke volume and heart rate, how to integrate the cardiac cycle, thinking about the mechanical events in the heart with the electrical events and so forth. So be sure you're familiar with all those ideas. In the very final video here, in the next video, I'll just do a quick summary of what we learned about systole and diastole, and maybe put in the context of looking at the heart as more than just a pump. All this discussion really is still stuck in a very pump-like analogy with the heart, but we might think of the heart from different perspectives as well, and I want to kind of summarize those, maybe looking at what we might call the phenomenological approach to understanding the cardiovascular system. And so I'll do that in the final video in the series.